Hi everyone, today we're going to talk about disorders of fluids, electrolytes, and acid-base balance. Sometimes it can seem a little complex, but I think you're all up to it. As always, we're going to talk a little bit about some of the normals before we go into the rest of it. But since you all have taken anatomy and physiology in the past, we probably won't be spending a lot of time talking about how things work. We'll start out talking about the composition and compartmental distribution of body fluids. The intracellular fluid compartment contains about 2/3 of the water of the body. It contains almost no calcium, small amounts of sodium, chloride, bicarbonate, and phosphorus, and moderate amounts of magnesium. However, potassium in particular is 28 times more concentrated in the cells than it is in the blood. The extracellular fluid compartment contains the remaining third of the body's water in the interstitial spaces and the plasma in the blood vessels. It contains high levels of sodium and chloride, moderate amounts of bicarbonate, and only small amounts of potassium, magnesium, calcium, and phosphorus. So let's review the movement of body fluids and electrolytes between the compartments. Electrolytes rely on transport proteins for movement across the cell membrane. Your book discusses the chemistry of cations and anion attraction and reminds you that any one of the same electrically charged ions can be exchanged for the other. This is especially important in acid-base balance. Last year I gave you a little pocket card with some normal blood values of the more common electrolytes. This would be a good time to review those levels. In your book, it gives conventional units and SI units in a chart on page 161. Most hospitals in the U.S. use conventional units. The SI units tend to be used in Europe and Canada. The concentrations that you will need to know are the extracellular levels. Water crosses by osmosis using aquaporins. These are special transmembrane protein channels. I use this diagram because later in pharmacology we will talk about medications that work directly on the aquaporin proteins, and I want you to have something in your mind to remind you of what they're talking about. Remember that in osmosis that water moves to areas where there is a higher concentration of solutes, meaning either proteins or electrolytes, or sometimes even a combination of the two. As the water moves across the semi-permeable membrane, it generates osmotic pressure. Your book goes further to discuss osmolality and osmolarity. You will often hear these terms used interchangeably, although really they shouldn't be. Osmolarity is a reference to fluids outside of the body, and it is used to discuss oral and IV solutions and how they'll affect the body or the cells in the body. Osmolality is used to discuss fluids in the body. So let's talk about a few more questions. An athlete ran a marathon, even though he felt ill. After the race, he collapsed. He was pale, with low blood pressure and sunken eyes. One knee and ankle were badly swollen. His abdomen was distended with fluid. The doctor diagnosed an appendicitis and dehydration. So let's look at these questions. What happened to his blood osmolarity? The blood osmolarity has increased. We see this because fluid has moved out of the circulating plasma and into the interstitial areas. In other words, swelling. Cell size has decreased. This is represented by his sunken eyes. When we talk about cell size, we're referring to tonicity, or the tension or effect that a solution with impermeable solutes exerts on the cell size because of water movement. Remember, the fluids are classified as hypotonic, isotonic, or hypertonic, depending on whether they cause the cells to shrink or expand. What about the transcellular compartment volume? Well, the transcellular compartment volume has increased, Again, the abdomen is swollen, so are the knees and the ankles. We call this third spacing, since the primary area of fluids in the extracellular space is plasma and interstitial areas. So what's happened to that vascular compartment volume? Well, it's decreased. We can tell this by the low blood pressure. There's not enough fluid to pump around, and the fact that he appears pale means the red blood cells are not able to release their oxygen load to the tissue due to decreased heart pumping. So some more question. What forces work to keep blood in the capillary? The capillary colloid osmotic pressure, COP, and tissue COP, the capillary hydrostatic pressure and tissue COP, the capillary hydrostatic pressure and tissue hydrostatic pressure, or the capillary COP and the tissue hydrostatic pressure. I'll let you think about it for a second. The answer is D, the capillary COP and tissue hydrostatic pressure. Hydrostatic pressure can be thought of as a pushing pressure, and osmotic pressure can be thought of as pulling pressure. Pressure in the capillary that is pulled to keep the fluid in, capillary COP, and pressure pushing fluid out of the tissue, tissue hydrostatic pressure, would result in more fluid in the capillary. Let's look at another scenario. It's a very hot day, and you fall down the stairs on the way to see the doctor about your hepatitis and renal disease. So the question is, explain why you have edema in your sprained ankle and foot. Well, edema is defined as palpable swelling produced by an increase in interstitial fluid volume. Since you may have had some edema in your ankle and foot, let's start there. Increased capillary pressure is related to your liver and kidney disease by increasing the vascular volume. In addition, depending on the type of renal disease, you may have low plasma proteins because of losing them in the urine, resulting in decreased colloidal osmotic pressure. The liver disease may also cause you to make less plasma proteins. Remember that we just talked about how low plasma proteins will cause more fluid to stay in the interstitial spaces. Finally, you fell down the stairs. So most likely you injured your ankle and foot, causing an inflammatory response with increases in the capillary permeability. So you've lost fluid into the interstitial space. Is that what you thought the reason was? If not, check out chart 8.1 on page 163. Think about some of the ways we assess for edema, like daily weights. So how do we control blood osmolarity? High osmolarity causes thirst and increased water intake. It also causes ADH release, and that results in water being reabsorbed from the urine. Remember, ADH stands for anti-diuretic hormone. And that means that water is reabsorbed in from the urine from the kidney back into the bloodstream. Low osmolarity causes lack of thirst, so you have decreased water intake. You also have decreased ADH release, so you don't lose water in the urine. Sorry, you actually lose more water in the urine because we aren't hanging on to it. When we look at water and sodium balances, sodium in the extracellular fluid is responsible for the distribution of fluids between the intracellular and the extracellular. Increased input of water results in decrease of body fluid osmolality and dilutional hyponatremia in the extracellular fluid. Decreased intake of water results in increase in body fluid osmolality and extracellular sodium concentrations. When we look at the total water and water balance, total body water is about 60% of your body weight in men, 52% in older men, and 50% of the body weight in women, or 46% in older women. Obesity decreases the total percentage of total body weight, sometimes to as low as 40 to 45%. Infants and young children have very high total body water at around 75 to 80% of body weight. Half of their total body weight is in the extracellular fluid, compared to adults with only a third of their total body weight in the extracellular fluid. Fluids in young children are normally figured at a rate of 150 milliliters per kilo per day if they're NPO, or higher if their metabolic needs or potential fluid loss is higher. There's one of those things that you could possibly get a math question about. So how do you figure out what their total fluids are if they're getting 150 milliliters per kilo per day? Well, you multiply 150 times their weight in kilograms, and that tells you how much fluid they'll get in the entire day. If it's all going to be in IV fluids, then we would divide that number by 24, and that tells us what our rate will be over the next 24 hours. Obligatory urine output is that which is required to remove waste products from the body. That's what we do no matter what. So even when we're dehydrated, we still will have a little bit of urine output. Insensible water losses is that which is lost by evaporation or from the moisture lost in respirations. So again, we think about sweat is one of the ways that we lose water through evaporation. When we look at the mechanisms of water and sodium regulation, there's two mechanisms for regulating body levels of water: thirst and antidiuretic hormone. The sympathetic nervous system and the renin-angiotensin-aldosterone system functions in regulation of sodium balance in the kidneys. So we have a number of thirst and thirst disorders. Thirst is the conscious sensation for the need to obtain and drink fluids high in water content. It's controlled by the thirst center in the hypothalamus. There's osmoreceptors that sense a decrease in osmolality by swelling or shrinking, depending on whether you have dehydration or you have more water in your system. A 1 to 2% change in osmolality will trigger the sensation of thirst. Cellular dehydration also works to tell us that we need to drink. And then a decrease in the effective circulating volume works on these osmoreceptors to tell us that we need to drink. There's not enough water circulating around our body. And then finally, production of angiotensin II by the renin-angiotensin mechanism in the kidney works on the non-osmotic thirst mechanisms. Hypodipsia represents a decrease in the ability to sense the need for thirst. It's a common problem in elderly people, especially if they've had a stroke, if they have confusion, they have sensory deficits, or motor disturbances. It's often related to trauma or lesions in the brain, especially around the area of the hypothalamus. Polydipsia is caused by heart failure or chronic kidney disease and may be related to increased angiotensin II levels. Dry mouth related to salivary function or treatment with drugs with anticholinergic actions like antihistamines or atropine can lead to decreased salivary flow and increased dry mouth. Psychogenic polydipsia is the result of compulsive water drinking and is usually seen in persons with psychiatric disorders, specifically schizophrenia. It's a compulsive behavior that occurs when they're having a relapse of their mental health disease. In addition, many antipsychotic medications can cause increased ADH levels and interfere with water excretion by the kidneys. In these patients, it can lead to water intoxication. Therapy consists of water restriction and behavioral measures, in addition to daily weights to monitor the degree of water consumption and excretion during therapy. So let's look at another question. True or false? Increased levels of ADH increase urine output. True. ADH prevents diuresis by causing more water to be absorbed in the kidney tubules. If more water is reabsorbed, there is less water left to eliminate as waste, and that decreases urine output. So let's look at that antidiuretic hormone and disorders of the antidiuretic hormone. Antidiuretic hormone, ADH, is also known as vasopressin. It controls the reabsorption of water in the kidney. It is synthesized in the hypothalamus. It's stimulated to be produced by increased serum osmolality or other factors, as little as a 1% change in osmolality. It's released by the pituitary gland into the circulation. So, how does it work? It binds to receptor cells in the collecting ducts of the kidney and promotes reabsorption of water back into the circulation. The aquaporin channels transport solute-free water through the tubular cells and back into the blood, leading to a decrease in plasma osmolarity and an increased osmolarity of urine. So let's look at one of the ADH imbalances. These imbalances are often considered to be endocrine disorders. So don't be surprised if you see these things discussed in your endocrine chapters in your other textbooks. There are two main ADH imbalances, diabetes insipidus and SIADH. These are normally considered to be endocrine disorders, like I said. Gestational diabetes insipidus is a form of this, and gestational diabetes insipidus is rare and occurs only during pregnancy and when an enzyme made by the placenta that affects the system of blood vessels and other tissues that allow exchange of nutrients and waste products between the mother and her baby destroys the ADH in the mother. It causes the body to retain too little water to function properly, leading to hypernatremia, changes in skin elasticity, low blood pressure, elevated blood sodium, leading to fatigue or lethargy, nausea, loss of appetite, muscle cramps and confusion, fever, headaches, and rapid heart rate. So that's one odd form, but we're going to deal primarily with the main form of diabetes insipidus, which is a deficiency of ADH or a decreased renal response to ADH. With that happening, the body is unable to concentrate urine despite water restriction. They excrete large volumes of water, up to 20 liters per day. Normal output is less than 3 liters per day. And we call this polyuria. Because of that polyuria, they have polydipsia, so they want to drink all the time, which is kind of good because they aren't concentrating their urine. In children, you may see fussiness, trouble sleeping, fever, vomiting, diarrhea, delayed growth, and weight loss. There's two different reasons why people get diabetes insipidus. The first is neurogenic. It's caused by damage to their brains. Usually it's caused by surgery, tumors, or meningitis, or often with head injuries. There's a few cases where it can be an inherited disorder in children. Nephrogenic is a defect in the kidney tubules. It's due to an inherited or genetic disorder or a chronic kidney disorder. There's certain drugs like lithium or some antiviral medications, cidofovir or foscarnet, that can also lead to nephrogenic diabetes insipidus. The treatment for diabetes insipidus is nasal, oral, or injectable forms of desmopressin acetate, or DDAVP. So naturally, since this is something that they're going to have to take for a while, you must do teaching. They can do surgery or radiation if a tumor is causing it. And they found that thiazide diuretics, specifically hydrochlorothiazide, is often works really well. I want to go back to the DDAVP because it's for the central or the neurologic version. And when we treat with the DDAVP, you should see a decrease in their urination as a sign that the DDAVP is working. Desmopressin should be considered a medication that the patient takes as needed. This is because in most people, the deficiency of ADH isn't complete, and the amount made by the body can vary from day to day. So some days they may need their DDAVP and other days they may not. And so that's going to be another one of those teaching points that you need to give your patients. Taking more desmopressin than needing can result in too much water retention and low sodium levels in the blood. Some of the symptoms that are associated with that include lethargy, headaches, nausea, and in more severe cases, seizures. In mild cases of central diabetes insipidus, you may need to only increase the daily water intake. The hydrochlorothiazide, it's used primarily with the nephrogenic DI, but it can also be used in both forms. The DDAVP is not used for nephrogenic DI because it is a problem with the way the kidneys are using the ADH, not a lack of ADH. If symptoms from nephrogenic diabetes insipidus are due to medications that are being taken, then we need to stop taking them. However, don't stop taking any medications unless the doctor says that that's okay. And the other thing, because these people are urinating large amounts of urine, we've got to make sure that they're getting plenty of intake of fluids so that we prevent dehydration. Another problem with ADH imbalances is syndrome of inappropriate ADH secretion, or SIADH. The syndrome of inappropriate ADH is a failure of the negative feedback system that regulates the release and inhibition of ADH. The body makes too much, causing high retention of water. Some of the causes of SIADH include medicines, like certain types of type 2 diabetes drug, some seizure drugs, some antidepressants, heart and blood pressure drugs, cancer drugs, and anesthesia. Some of the other causes can be receiving hormone medicines such as ADH or vasopressin. Remember, if you take too much, it can actually lead you, if you take too much with DI, it can actually put you into SIADH. For some people, having surgery under general anesthesia can cause them to go into SIADH. If there's disorders of the brain like injuries, infections, or stroke, that can cause SIADH. Lung diseases like pneumonia, tuberculosis, cancer, and chronic infections can also trigger SIADH. Some of the more rare causes are diseases of the hypothalamus or pituitary, cancer of the lungs, small intestine, pancreas, brain, and leukemia, and some mental disorders. The signs and symptoms of SIADH is hyponatremia. With hyponatremia, we get confusion, disorientation, and delirium. There may be generalized muscle weakness, myoclonus, tremor, asterixis, hyporeflexia, ataxia, and dysarthria, Cheyne-Stokes respirations, which is usually what we see just before somebody dies, pathologic reflexes, which are going to be things that we see in people that have neurologic disorders, generalized seizures, coma, chronic pain, symptoms from the central nervous system, or pulmonary tumors, or head injury, or drug use is often associated with it. Treatment is to correct the hyponatremia. We do that primarily through fluid restriction. If we're able to do it with fluid restriction, that may be all we do. But if that doesn't work, we may use vasopressin agonists. In other words, we're causing vasopressin not to be produced. Loop diuretics can also help in some cases, as well as increase salt intake. So question, which will cause hyponatremia, DI or SIADH? Let's think about that. Well, the answer is SIADH. DI is going to have a normal sodium level, where SIADH, because of the dilution that's going on with it, is going to cause hyponatremia. So let's talk a little bit about isotonic fluid volumes, in this case, deficit. With the isotonic fluid volume deficit, we see decreased extracellular fluid, both in the interstitial areas and also in the blood vessels. It occurs when water and electrolytes are lost in equal proportions. Some of the signs and symptoms include decreased weight, thirst, decreased urine output, decreased tissue turgor, and decreased capillary refill. We assess tissue turgor by actually picking up the skin and seeing how quickly it returns to its normal shape. And with capillary refill, we know that we put pressure over a bony area and then hold it for about 15 seconds, 5 to 15. And when we lift our fingers up, we count to see how many seconds it takes for the normal color to return to that area. Treatment for isotonic fluid volume deficit is fluid replacement, and treatment of whatever has caused them to lose this water and electrolytes in the first place. When we look at isotonic fluid volume excess, we see increases in both the interstitial and intravascular volumes. Often, if it gets excessive, it can become something that we call circulatory overload, and that becomes a really big problem. The signs and symptoms of isotonic fluid volume excess is weight gain over a very short period of time. We may see edema, and what's interesting about the edema that we see is if it's a chronic condition, it may actually hide the fact that this person isn't eating properly. And they may not be eating properly because of other symptoms that go along with this. We see central venous pressure increases. This can cause distension of the neck veins, slow emptying of the peripheral veins. So in other words, when we're checking that capillary refill, it's going to be, it's not going to seem to get pale when we put pressure on it as in the time period that we would normally expect it to. We'll see full bounding pulses when we feel for pulses, and there'll be an increase in the central venous pressure. Usually central venous pressure needs to be measured by an internal pressure line, so it's not something that you'll see just by doing a blood pressure. If the patient starts to retain fluid in the lungs, they'll develop pulmonary edema. And the symptoms of pulmonary edema are things like shortness of breath, difficulty breathing. When you listen to the lung sounds, you'll hear crackles and they'll sound wet. They'll also have a productive cough. Often we say with the productive cough, it'll be pink tinged at times with severe pulmonary edema. In severe isotonic fluid volume excess, we may see ascites develop in the abdominal area and pleural effusions. The treatment of isotonic fluid volume excess is to start out by trying to control the sodium levels, because the sodium is causing them to retain that fluid. So we want to give them a sodium-restricted diet. They'll be on diuretic therapy because that will help them to lose the sodium in their urine. And if these patients need to be on IV fluids or have blood administered to them, we're going to be watching very closely for signs that their condition is deteriorating. So let's talk about these cations and that we've been mentioning earlier in this lecture. Sodium is a normal level is 135 to 145 milliequivalents per liter. It regulates extracellular fluid volume and osmolality. Hyponatremia is when the sodium level is less than 135 milliequivalents per liter. There's a lot of issues involved with it, and often we look at volume issues as far as is the volume low, hypovolemic, do they have normal volume, or is their volume too high, hypervolemic? We combine that with osmosis issues. For instance, a patient may have hypovolemic, hypotonic hyponatremia, and it's the most common type of hyponatremia, and it occurs when water is used to replace the loss of isoosmotic body fluids. So this is one of those times when in hot weather somebody goes, wow, it's really, really hot, and they're just drinking straight water rather than an electrolyte solution, and so they become diluted. And then there's other combinations where you could have hypertonic, hypovolemic, but in general, there's the bottom line is that the sodium levels are low. If you look in the previous slides when we were talking about DI and SIADH, we have the signs and symptoms of hyponatremia there. So no need to take up space at this point. The treatment is based on whatever the underlying cause is, and the goal is to return the sodium to normal levels. Like we discussed the other day in pharmacology, this is done slowly, over hours and even days, and that's due to the risk of osmotic demyelinization syndrome. Hypernatremia is when we have a sodium level that's above 145 milliequivalents per liter. Hypernatremia is a water problem. It's not a problem of the sodium homeostasis. The groups most commonly affected by hypernatremia are the elderly and children. There is actually a form of hypernatremia that's associated with breastfeeding in the neonatal period, and it's usually seen in infants that are less than 21 days of age, and they have not started to gain weight. Normally babies start to gain weight at about day 5 after birth, and they normally lose less than 10% of their birth weight. Well, these children, if they're not getting enough breast milk, either because mom thinks they need to be on a schedule and she's feeding them every 3 to 4 hours, or there's some kind of mechanical problem where maybe they're tongue-tied so they're not able to get the milk to flow as well as they should be, or maybe mom has a problem in her breasts where she isn't producing enough, or she's had surgery on her breasts that have caused her not to produce as much. These kids will show up in the hospital not having very low urine output. Some moms get really confused when we say, do they have a wet diaper? And they'll say yes. And we have to take the question a step further and say, on the diaper, how much of it is wet? And sometimes they'll take their hand up and they'll show us a quarter-size circle is all the kid is voiding because they're not getting enough fluids in. So that's kind of a unique situation, but it still is one of the examples of why hypernatremia can happen in at least children, infants. Both in and out of the hospital, generally elderly people who are mentally and physically impaired are more often affected, and they often have an acute infection as part of the big picture of why they have hypernatremia. In both areas, in and out of the hospital, hypernatremia is caused by impaired thirst and or restricted access to water, and it's often exacerbated by pathologic conditions with increased fluid loss. The manifestations of sodium imbalance of hypernatremia is lethargy, confusion, abnormal speech, irritability, seizures, nystagmus, myoclonic jerks, orthostatic blood pressure changes, tachycardia, oliguria, dry oral mucosa, abnormal skin turgor, a dry axilla, even though it's hot, weight loss, and generalized weakness. The treatment for severe hypernatremia is correction of the sodium at an initial rate of 2 to 3 milliequivalents per liter per hour for the first 2 to 3 hours. The maximum correction is going to be 12 milliequivalents per liter per day. So if somebody has a sodium level of 162, we're not going to expect to see their sodium level go back to 140. We're going to expect their sodium level in one day to go down to 150. And the next day, we're not going we're not going to see it go all the way back down to 140. We're going to see it more like 144 because we're going to decrease it very slowly. For mild or chronic hypernatremia, the correction of sodium is an initial rate of a half of milliequivalent per liter per hour for a maximum total correction of 8 to 10 milliequivalents per liter per day. We're going to measure, especially for severe hypernatremia, we're going to measure electrolytes every 1 to 2 hours. We're going to monitor their neurologic status very, very closely because, again, we're worried about them having the effect of getting too much fluid too quickly and the cells expanding very quickly from that increased fluid and having lysis, and especially in the neurologic system. We're going to monitor fluid replacement. If they're hypovolemic, we're going to give them normal saline before we give them any free water. So in other words, we're going to give this fluid that we're replacing. Remember, I talked to you about the fact that it's one of those things where in your mind you go, well, their sodium is low, so they should have a solution that doesn't have any sodium in it. But no, if we do that, we're going to expand that extracellular space too quickly, and it's going to cause cells to lyse. So we're going to give them normal saline in their solution, and then when their body starts to have a more normal level of sodium, then we're going to give them water to drink. Then we're going to give them IV solutions that don't have sodium in them. Thiazide and loop diuretics increase the sodium loss through the kidneys, so that's another thing that we may give them to help this sodium level return to normal. But again, if you've got dehydration associated with it as well, we don't want them urinating out what little bit of fluid they have. So let's talk about potassium. As we know, most of the potassium sits inside of the cells. So the extracellular serum levels are 3.5 to 5 milliequivalents per liter. This maintains the intracellular osmolarity. It controls the cell's resting potential, and it's needed for the sodium-potassium pump. It's also exchanged for hydrogen to buffer blood pH. The factors that influence the extracellular intracellular shift in potassium are the serum osmolality, the acid-base balance, insulin, and the increased sympathetic nervous system activity. Increased serum osmolality causes potassium to move outside of the cells. And as far as acid-base is concerned, in acidosis, hydrogen moves into the cell for buffering, and that causes potassium to move out of it. And so you can see how potassium is very involved in the acid-base balance. Both epinephrine and insulin cause cellular uptake of potassium by increasing the activity of the sodium potassium adenosine triphosphate membrane pump. Insulin not only regulates our blood glucose, but causes extra potassium to be driven into the cell until the kidney can eliminate it from the urine. So back to that acid-base balance, what will happen if the patient has a high potassium level that's acidotic? If the cells are full of potassium, then there is the ability to exchange the hydrogen for potassium, but that will result in a higher level of potassium in the blood. So thinking back to what we talked about in pharmacology, what drug do we give for high potassium levels? Well, we give Kxalate, or we can also give insulin, because that will drive that potassium back into the cell. But then, of course, we end up with acidosis because the hydrogen coming back out. If the cell already has a lot of hydrogen atoms, then the hydrogen cannot move into the cell and the acidosis cannot be resolved. And the potassium levels will still be high and it needs to be taken care of. But in that case, there's no place to shift with the hydrogen. So the patient would probably need some sodium bicarb to help neutralize the hydrogen, which of course we're looking at metabolic acidosis when we're talking about these things. Potassium plays a critical role in conducting nerve impulses and controlling the excitability of skeletal, cardiac, and smooth muscles. It does this by regulating the resting membrane potential, or some people just say the resting potential of the cells. It does it by regulating the resting membrane potential, the opening of sodium channels that control the flow of current during the action potential and the rate of depolarization of the cells. This is especially important when we're thinking about the heart. The resting potential is determined by the ratio of the potassium concentration outside of the cell compared with the potassium concentration inside of the cell. A decrease or hypokalemia causes the resting membrane potential to become more negative, and that moves it further from the threshold for excitation. So it takes more stimulation for it to reach its threshold potential and open those sodium channels that are responsible for the action potential. An increase in the extracellular fluid potassium levels, or hyperkalemia, has the opposite effect. Repolarization is more rapid in hyperkalemia and slower in hypokalemia. The little chart with the black and the blue and the red lines shows the effect of hyper and hypokalemia on the resting membrane potential. And the drawing shows how the differences in voltage will result in hypo versus hyperkalemia. Hypokalemia is when the potassium level is less than 3.5 milliequivalents. Some of the causes involved with it are inadequate dairy intake and excessive renal, GI, and skin losses. Renal losses in particular occur when patients are on diuretic therapy, except if they're getting potassium-sparing diuretics, or if they have metabolic alkalosis, low magnesia, trauma, stress, and increased aldosterone levels. A shift between ICF and ECF happens because it can happen because of decongestants or bronchodilators, insulin, and some other drugs, where potassium moves in or out of the cell because of the effect of these substances. The manifestations of hypokalemia include alterations in neuromuscular, GI, renal, and cardiovascular function. There's a table on page 179. Take a look and see the details of how it affects their function. It can cause a decrease in the resting membrane potential in the heart, causing the PR interval to be prolonged, as well as the repolarization of the ventricles. It can also increase the risk of toxicity from digoxin, which would lead to arrhythmias. In addition, just having low potassium levels can also cause arrhythmias. The treatment is dietary supplementation. if it's a low level. If it's a mild level of hypokalemia. If it's more severe, then we may want to do an IV infusion of potassium. Remember, when we're giving IV infusions of potassium, that it's going to be diluted, it's going to be given slowly over several hours, and the patient needs to be on a cardiac monitor to monitor for arrhythmias. Hyperkalemia is greater than 5.5 milliequivalents per liter. Some of the causes are unusual. Some of the causes, it includes the fact that it's very unusual for healthy individuals to have hyperkalemia. But one of the causes can be a decrease in renal excretion, and it's the most common cause. Chronic hyperkalemia is almost always associated with chronic kidney disease. Aldosterone deficiency can increase tubular reabsorption of potassium in the renal tubule, and we see that with adrenal insufficiency. We can also, if there's an increase in the shift of potassium from the intracellular fluid to the extracellular fluid, then we'll see, for whatever reason, we'll see hyperkalemia happen. Again, I want to refer you back to the table on page 179, but we see neuromuscular symptoms. Usually numbness is the first symptom that we see, and then we see cardiac symptoms, specifically changes in the ECG readings, and we also see arrhythmias. The treatment of hyperkalemia, we can give calcium as an antagonist for potassium, and it is protective for the heart. We can give insulin, albuterol, and sodium bicarbonate to drive the potassium from the extracellular fluid into the cells. Remember, we also talked about polystyrene sulfonate, which is Kayexalate, that can be given either orally or rectally to decrease the potassium. It draws the potassium out of the cells. Also, if it's just a slight imbalance, we can give a diet low in potassium. The normal level for calcium is 8.5 to 10. 99% of calcium is found in the bone, where it is used to increase the extracellular levels of calcium. It provides strength and stability to the bones. It also works to provide membrane potentials and excitability, especially in the heart. This mineral, other than a source for the bone, is like the cation potassium in that it is primarily found in the intracellular fluid, and very small amounts are found in the blood, although there are larger amounts of calcium in the extracellular fluid than potassium. Make sure, as you're learning the normals, that you distinguish the differences between milliequivalents per liter and milligrams per deciliter. We've been talking about sodium and potassium as being milliequivalents per liter, which is small size or amounts. With calcium, we're talking about milligrams per deciliter. 40% of extracellular calcium is found protein-bound with albumin and plasma proteins. This means when albumin levels are low, that the serum calcium levels will also be decreased. 10% of calcium is complexed. That means that it's found in joined with citrate, phosphate, or sulfate. So in other words, we have calcium citrate, calcium phosphate, calcium sulfate. Finally, 50% of calcium is ionized. The ionized calcium is the active form of calcium that's able to be utilized in cellular functions. Ionized calcium levels are affected by pH. When the blood is more alkaline, meaning that our pH is a higher number, more of the calcium becomes bound to the plasma proteins. So the serum levels of ionized calcium would be decreased. But when there is acidosis, more of it is set free from the protein, so the ionized calcium levels would be higher. Ionized calcium does what is up there on the slide. It participates in the release of hormone neurotransmitters. And calcium is also involved in clotting factors. So calcium enters the body through the GI system, through what we eat, under the influence of vitamin D, which is excreted in the kidneys. The calcium is stored in the bone until it is needed by the body. Dietary calcium that is not needed is excreted in the stool. The kidneys are the excretory vehicle after calcium is in the bones and in the blood. In the kidney, the ionized calcium is filtered out and then either removed in the urine or reabsorbed back into the blood. The parathyroid glands are what helps to control the calcium levels in the body. It senses the calcium levels in the blood and secretes parathyroid hormone that helps to determine, along with vitamin D, how much ionized calcium will be returned into the blood in the kidney, as well as how much vitamin D will be released to influence the absorption of calcium from the GI system and the release of calcium from the bones to maintain a normal calcium level. Calcium is one of those minerals that if we don't eat enough, our body's going to maintain the calcium levels on its own, and it will cause breakdown of the bones. One of the things that we have to look at with pregnant women is whether or not they're getting adequate calcium intake, because with a growing baby, there's even a higher level of calcium that's needed for the mother to produce in order to make strong bones for her baby. And the baby's going to take whatever amount of calcium it needs from its mother. And the mother's body still needs calcium of its own, so it's going to break down more of her bones and teeth in order to get it. There used to be a saying among women in the olden days that a tooth for every baby. In other words, they lost a tooth out of their mouth for every baby that they had, toothless mothers. Basically, what they were observing was that because of their low calcium intake, the baby had taken calcium from their body and it affected their dental health. Extracellular calcium controls nerve firing. With hypocalcemia, nerves fire more easily, and with hypercalcemia, nerves are less able to fire. So the question is, which would cause the Trousseau sign? And that's the hypocalcemia. Trousseau sign is a sign of too much excitability of the nerves. And we'll talk about that in just a minute when we talk about hypercalcemia. Hypocalcemia is when total serum calcium levels are less than 8.5 and ionized calcium is less than 4.6 milligrams per deciliter. We can get a pseudo hypocalcemia, and that's caused by hypoalbuminemia. And with that usually takes place as a problem with renal failure. It causes decreased production of activated vitamin D and increased levels of phosphorus. And since the level of calcium and phosphorus are kind of like teeter-totters, when the phosphorus levels are high, the calcium levels are low, and vice versa. If there's an impaired ability to mobilize calcium from the bone due to hypoparathyroidism, the parathyroid hormone can be suppressed because of high levels of vitamin D or magnesium deficiency, or if they have hypoparathyroidism. Also, acute pancreatitis can also be a player in the inability to mobilize calcium. If there's increased protein binding or chelation, this happens when we end up getting the complex forms more than the ionized state, or it becomes bound to proteins. If calcium levels are too high, or any level of minerals are too high in the body, we can give medications to chelate or bind them so that they're no longer actively acting in the body. The manifestations of hypocalcemia, if it's mild, there may be no symptoms at all or just minimal symptoms. With acute, we have increased neuromuscular excitability and cardiovascular effects. In other words, the heart is having arrhythmias because the electrical activity is firing too much. With chronic, we may have osteomalacia and bone pain. The treatment for acute hypocalcemia is an IV infusion of calcium gluconate. Calcium gluconate is a little safer than calcium sulfate. It may cause arrhythmias, so that you should be monitored with a cardiac monitor if the hypocalcemia is severe, or there's comorbidities or medications that can potentiate arrhythmias. It's usually given over at least 15 to 30 minutes, and the patient really should be in the ICU on a monitor if it's given that quickly. Otherwise, we look at it given over an hour or two, sometimes even 3 or 4 hours. If there's chronic hypocalcemia, we may start somebody on oral calcium intake, and often they need vitamin D to help them to absorb the calcium. With hypercalcemia, the total calcium levels are greater than 10.5. And it can be affected by if your tourniquet is too tight when you're drawing the calcium level, it may cause a higher level, or if there's increased serum albumin levels. The causes can be calcium movement into the circulation that overwhelms the calcium regulatory hormones, or the ability of the kidney to remove the excess calcium ions. This can happen because of neoplasia, hyperparathyroidism, prolonged immobilization. We talked about how when people don't move and they don't have weight-bearing activities, how the bone will start to break down. Well, as the bone gets softer and breaks down, there's more, that's called osteoclastic activity. That calcium is released out into the system. It can also be caused by increased intestinal absorption of calcium, if there's high or toxic levels of vitamin D, and certain effects of drugs like lithium and thiazide diuretics. Hypercalcemia treatment is rehydration, and loop diuretics or calcium chloride, which increases the urinary elimination of calcium. Biphosphonates inhibit osteoclastic activity, and that decreases bone resorption, which means it decreases the breakdown of the bone, and so it doesn't put as much calcium out into the blood. It keeps it in the bone. Calcitonin also inhibits osteoclastic activity, and steroids inhibit the conversion of vitamin D to its active form, and they're used to treat hypercalcemia due to vitamin D toxicity and hematologic malignancies. So we've talked about calcium. Let's talk about its opposite friend, phosphorus. The normal levels of phosphorus is 2.5 to 4.5 milligrams per deciliter, and 85% of phosphorus is found in the bone and the intracellular fluid, about 14%. Levels are often higher for phosphorus in children, probably because of the effect of growth hormone on the child. Like calcium, it's acquired through dietary sources. It exists in two forms, inorganic and organic. The inorganic form is circulating in the blood, so you might say it's the active form. The intracellular form is the organic form. It's needed for a number of different things, like bone and ATP formation in the cell, glucose, fat, and protein metabolism. The phosphorus is needed for the enzymes that break down the glucose, fat, and protein. It's also in the DNA, RNA, and phospholipids. Obviously, we've got phospho with lipids, so it's there with that. It's also part of the acid-base buffer system, and it is involved with red blood cell, white blood cell, and platelet function. In hypophosphatemia, the causes are insufficient intestinal absorption, transcompartmental shifts, increased renal losses, and it manifests by using altered neural function, disturbed musculoskeletal function, hematologic disorders. The treatment is prophylactic. We make sure that we have a dietary intake that's sufficient in phosphorus, which we know is readily available in milk. Supplements are contraindicated if there's hyperparathyroidism, chronic renal failure, and hypercalcemia due to increased risk of extracellular calcifications. So in other words, what this means is if you have any of these disease states, that it will cause calcifications out in the tissues. If hypophosphatemia is severe, we may give intravenous replacements. Hyperphosphatemia is caused by failure of the kidneys to excrete excess phosphate. There's a rapid redistribution of intracellular phosphate into the extracellular area, or high phosphate intake. The manifestations are tetany, paresthesias, hypotension, and cardiac arrhythmias. The treatment is dietary restrictions and calcium-based phosphate bond binders. So in other words, we're giving calcium to bind that extra phosphate. There's also a drug known as sevelamer. It's non-calcium and aluminum-free phosphate binder. In severe cases and in people with kidney failure, phosphate is removed through hemodialysis. Before I go on to talk about magnesium, I want to go back to hypocalcemia a little bit, because I told you that I would talk about the Trousseau test. It's also given with the Chevostek test as well. The Chevostek sign is when you tap on the face just below the temple area at the point over the facial nerve. If it's a positive test, there will be spasms of the lip, nose, or face, which means those spasms are going to cause those muscles to contract. Normal should be negative. We shouldn't see that contraction happen when we tap on the face below the temple. The Trousseau sign is when you take a blood pressure cuff and it's inflated around the arm for 3 minutes. When that happens, you get a carpopedal spasm, and it causes contractions of the fingers and the hand, and that's a type of tetany, and that's considered a positive sign. And obviously, we should, if you have normal levels of calcium, you shouldn't get this contraction of the hands. So that's those signs. I suddenly realized I hadn't talked to you guys about that. Magnesium is also one of those drugs that we're going to talk just very briefly about, because disorders about magnesium are a little more rare, and so we're not going to spend a lot of time with that. Normal levels are between 1.3 and 2.1. It's ingested in the diet. It has cofactor enzymatic reactions. It's involved in ATP generation, DNA replication, and messenger RNA production and translation. It also can prevent arrhythmias by blocking the potassium exiting from the cardiac cells. It's also a smooth muscle relaxant. Because of that action, it is given to pregnant women who have something known as preeclampsia or eclampsia, which is a very serious condition that occurs in women only during pregnancy. And you'll learn more about the causes and everything of preeclampsia and eclampsia when you take OB. But one of the things that happens, especially when a woman moves from preeclampsia into eclampsia, is they get seizures. And magnesium can be used as an anticonvulsant because it relaxes the smooth muscles. And so often when a woman is diagnosed with preeclampsia, she's started on magnesium IV infusions. It slows down the excitability of the cells as the potassium is exiting it. So it will slow down everything. The side effect of receiving magnesium IV is constipation and generally just not feeling very good because your whole system is just kind of slow. And babies whose mothers have been on magnesium to prevent eclampsia often come out and don't have a bowel movement for a couple days. This causes them to absorb more of their bilirubin from their stool, which we'll talk more about bilirubins and everything later on. But so they have a tendency to have jaundice more. We usually start giving them some glycerin to stimulate bowel movements, usually glycerin suppositories in babies. Moms, we may give them a stool softener and something to get them to have regular bowel movements and not strain with them. So like I said, this is one of those things where it's more of a case of I want you to generally know about magnesium and what it does, but I don't expect you to know hypo, hyper, because those abnormalities are rather rare. So finally, we're going to talk about acid-base balance. When we're talking about acid-base balance, we're talking about the production of hydrogen or acid. That hydrogen, those acid levels help control the respiratory rate. When it's higher, we breathe faster. When it's lower, we breathe slower. One of the things that can be formed when CO2 combines with water is we can get carbonic acid or H2CO3. That's considered a volatile acid. Non-volatile are things like lactic acid as a result of energy metabolism, or hydrochloric acid that we have in our digestive system, or keto acids, which are actually food for our brain. For those of you that are visual, this is just, again, a visual representation of how the buffer systems work in the body. And when we talk about the buffer systems, we're talking about the lungs and the kidneys. So review this, it's in your book as well. pH, the normal pH is 735 to 745, and it is regulated by the chemical buffer systems. The chemical buffers immediately combine with excess acids and bases to prevent large changes in pH. The lungs eliminate CO2, and the kidneys eliminate the hydrogen by reabsorbing and generating bicarbonate. I'm not going to spend a lot of time over how this works because you should have learned that in anatomy and physiology, or you should be reviewing that in MedSurg. The next couple of slides will briefly review how the lungs and the kidneys do these things. Respiratory or volatile acid phase is when CO2 is combined with oxygen to give us carbonic acid. The carbonic acid can then lose one of its hydrogen or combine with hydrogen with bicarb, and then it becomes the carbonic acid. An increase in CO2 will cause increases in pCO2, or the partial carbon dioxide. Increases in acid gives us a lower pH. Increases in the bicarbonate ion gives us higher pH. When we look at metabolic or non-volatile acid, increase in metabolic acids raise the hydrogen levels. Some hydrogen combines with bicarbonate, and that decreases the amount of hydrogen in the system. Breathing adjusts the CO2 levels to bring the pH back to normal. Remember that metabolically, it is much slower for our kidney to change the pH with the bicarb being produced in the kidney and the urine increasing its acid than it is for us to breathe a little faster and blow off a little more CO2. With metabolic acidosis, we have increased levels of keto acids, lactic acids, etc., and decreased bicarbonate levels. So when we look at a blood gas, we're going to see a change. We're going to see an acidotic pH, and we're going to see decreased bicarbonate levels. With metabolic alkalosis, we're not going to have as many hydrogen molecules, so we're going to have alkalosis in our pH, so an increased level of pH, and increased bicarbonate levels. So our bicarb is going to be high. So let's put this into practice. Here's our scenario. A woman was given an acidic IV. Soon she began to breathe more heavily. When her blood was tested, it had slightly lowered pH, low bicarb, low PCO2, slightly increased potassium. Her urine pH was slightly lower. Why did these responses occur? So if you remember back in fundamentals, we didn't talk about compensatory mechanisms because at that point I just wanted you to be able to identify whether something was metabolic or respiratory acidosis or alkalosis. Now we get to talk about compensated or partially compensated acidosis and alkalosis. In this scenario, the woman had her acid levels increased by receiving the acidic IV fluids. If we had gotten an ABG early in this scenario, we would have seen that she had metabolic acidosis. The fastest way for the body to compensate for the increased acid is for her to breathe faster and expel the CO2. A slower method of relieving the acidosis is for the kidney to lose acid in the urine, hence the urine pH that's lower than what we would expect, and to put more bicarb back into the blood. So when we look at her ABG, we see that her pH is only slightly low because these compensatory mechanisms have been put in place, but they haven't completely changed her pH to a normal pH. Her PCO2 is low from breathing heavily and blowing off her CO2. And her potassium is slightly increased because acidosis has driven it out of the cell, and the bicarb or the acid is moving into the cell to become buffered. So what we might see right at this point is that her pH is a little bit low, but her body is trying to compensate. So we would have metabolic acidosis because we have low bicarbonate and a low pH that is partially compensated because of the low CO2. It's only partially compensated because she hasn't been able to blow off enough CO2 to make her pH normal. So I'm thinking that you probably need some practice with this. So let's remember a few things when we're looking at blood gases. The first thing that we look at is the pH. Is it acidotic? Is it alkalotic? Or is it normal? Does it fall within that normal range of 735 to 745? If it's normal and we have abnormalities in the bicarb, let's say in this example that the bicarb is low, but our pH is normal, then we can assume that we have metabolic acidosis that has been compensated. If it's compensated, then we're going to see that our CO2 levels are high because are low. I'm sorry. We're going to see that our CO2 levels are low because we've been blowing off that CO2. If we look at that pH, and the pH is low, and our bicarb is low, then we're going to see that we have a metabolic acidosis that is not compensated. If the pH is kind of getting close to normal and the CO2 is low, then we can say that it's partially compensated. I'm going to give you all some examples to work through with an answer sheet that will tell you whether they're what type of ABG you're looking at so that you can get some practice with this. I am expecting that some of you, even after you do the practice, are going to be going, I still don't really understand this. Oh, Ms. Foreman, please help me. And I am more than willing to help you guys to understand how to read ABGs and to determine whether they are normal, whether they're compensated or uncompensated or partially compensated, and to work with you. It would be best if we can do that either in small groups or at least in groups rather than individuals, just because it will use my time a little more efficiently. Right now with our offices being up in Evans, and they're kind of, I don't know if all of you have been up there or not, but basically my office is shared with 3 other people. So it's not as private as it was or it will be, but we can go into another room and work on that. We're not being required to be in our offices as much because of that. Also, my office hours are primarily on Mondays and Wednesdays. Some of you have come by and seen that I don't have any office hours on Tuesday and Thursday. That does not mean that I won't come in and work with you if that's the only time that you can come and learn about these things. So if you will email me, it will help me to be there in my office or to come in so that I can help you with these. So email me if you want to have some review about these, and we can run more and more as we're working on them. And that ends this lecture.